Good morning. My name is Samantha Gennison. I am here today to talk about asthma. My presentation will cover the clinical manifestation of asthma, and I will also highlight the pathogenesis causing the clinical manifestation by drawing on the case study of Mr. Jackson Smith. Before I go into pathogenesis that's causing the clinical manifestation with Mr. Jackson Smith, I would like to briefly explain his condition or a case a little bit here. Mr. Smith is an 18-year-old male admitted to emergency department for severe breathlessness. As his family mentioned, he also been diagnosed with asthma when he was 2 years old. Mr. Smith has a few clinical manifestations on the admissions to emergency department. The first clinical manifestation that I would like to point out is severe dyspnea, which is inability to speak sentences in one breath. Second clinical manifestation that I would like to point out is his respiratory rate is 32 breaths per minute, which is above his normal range. He also has a low oxygen saturation, which is 94% on room air. His pulse rate shows high, which is 130 beats per minute. His osculation of lungs has wheezing and diminished breath sounds. His chest X-ray shows clear and hyperinflated lung fields. Do you know in Australia, asthma is the second most common illness according to Australian Institute of Health and Wellness 2019? First, what is asthma? Asthma can be defined as chronic inflammatory disorder of the airway that is associated with airway hyperresponsiveness, repetitive episode of wheezing, breathlessness, chest tightness, cough particularly at night and early morning, according to National Asthma Council Australia 2019. The episode of variable in nature but widespread obstruct occurs and they are reversible either spontaneously or with treatment. According to National Asthma Council, Australia 2019 is estimated around 300 million worldwide affected by this disease. With classical asthma, or known as allergic asthma, the initial immunological trigger for development of symptoms is exposure to an inhaled allergen, for example, pollen. When the allergen reaches epithelium of trachea or bronchi, it might be cleared from the body by mucociliary transport, avoiding immunology response completely, or it could be taken up by a cell type called dendritic cells, which exist throughout the body, including the airway epithelium, according to the Jordan Kraft 2019. Dendritic cell, which contains numerous sheets-like extension of cell membrane, act as antigen-presenting cells, according to the Jordan Kraft 2019. This means that they take out antigen like allergens, process it, and then present it to T lymphocytes in the airway mucosa. Depending upon the circumstances, this could activate a cell type called CD4 helper type 1 or CD4 T helper type 2, according to the Jordan Kraft 2019. Relative overexpression of type 2 instead of type 1, which due to combination of genetic and environmental factors, is a major aspect of allergic asthma, according to Jordan Kraft 2019. Once dendritic cells presented the process allergen to T helper 2 cells, there are two key consequences according to the Jordan Kraft 2019. One response, the release of chemical mediator called IL-5, which increases the activity eosinophil, which then are responsible for the release of cytokinesis and leukotrienes. The second consequences of T helper type 2 is stimulation of type B lymphocytes are called plasma cell that release antibody called IgE, which then binds to mast cells, which promotes the release of histamines, leukotrienes, and prostaglandin and D2, according to the Jordan Kraft 2019. Thus, exposure to the environmental allergen leads to activation of T helper cells. Thus, exposure to environmental allergen leads to activation of T helper cells, eosinophil cells, plasma cells, and mast cells with end result release of pro-allergic and pro-inflammatory compound histamine, leukotrienes, cytokinesis, and prostaglandin D2, according to Jordan Kraft 2019. The immediate acute response to the chemical mediator is the combination of bronchospasms, bronchial wall edema, and increased mucus secretion, according to the Jordan Kraft 2019. Chronic exposure for triggered allergen will eventually lead to bronchial hyperresponsiveness, chronic bronchial wall inflammation, and airway smooth muscle hypertrophy, which could lead to some degree of airway obstruction, even in between of exacerbations, according to Jordan Kraft 2019. In consequence of airway obstruction, which then leads to increased mechanical work of breathing and is severe, will lead to hyperventilation and eventually hyperinflation and life-threatening gaseous abnormalities, according to Jordan Kraft 2019. Now I would like to draw your attention to the clinical manifestation of asthma. The diagnosis of asthma is based on patient's history, physical examination, considering other diagnoses, and also documenting variable airflow limitations. Asthma can damage the airways in the lungs, which leads to signs and symptoms such as chest tightness, severe dyspnea, wheezing sound, which when exhaling and coughing, especially at night or early in the morning, according to the National Asthma Council Australia 2017. Those are the common patterns or symptoms in people who have asthma. People with asthma get triggered by exercise, viral infection, such as cold air, allergies, laughing or crying, or known as hyperventilations. Finally, the clinical patterns of immunology process underlying asthma are different between individuals. My presentation has covered the pathogenesis and clinical manifestations of Mrs. Smith, who has been diagnosed with acute exacerbation of asthma. To conclude, based on the clinical manifestation identified, it is evident that Mrs. Dr. Smith's condition is chronic inflammatory disorder. Thank you for your time and attention.